sais pas quel est.
Really having a history of photosensitivity, so every summer it came back, it became worse, and then we had this histological confirmation of superacute dysquadritism in 2022, and then we started to follow it. Il faut peut-être enlever le rhumatologie parce que c'est pas rhumatologie.
En fait, pendant le truc,
So then we started to follow her in the departments. I studied since 2022. We did some biological follow-up. Okay, we are not rheumatologists, but we did some initial tests. And so the anti-nuclear antibodies were positive. We had an anti-DNA, so low positive but present, and anti-SSA was also low. On dit pas low positive, on dit.
Ah, mais il y en a un que t'as pas mis.
Juste positif.
Ouais, moi je mettrais positif.
1, 2, est-ce que le
Non,
micro
mais pas low,
fonctionne?
je tombe sur le terme maintenant. Slightly positive, un truc comme ça, mais tu peux le dire.
Comme ça.
Tu peux le dire.
Qui disait 1, 2, 1, 2. J'ai l'impression. Tu veux que je parle dedans, moi?
J'ai entendu la
1, 2, 3
I think
test.
there was hypocomplementemia.
1, 2, 3.
We also looked for antiphospholipid antibodies, but she never
1, 2,
suffered
3
of any
test.
thrombosis or history. But she was also complaining of joint pain, about inflammatory joint pain without synovitis. However, as far as we checked, there was no renal neurological visceral involvement. Now, what did we do with this patient? We had also regular recommendations, so photoprotection and topical treatments. We insisted on the importance of the SPF 50 or even SPF 100. And then in June we started her on hydroxychloroquine, 200 milligrams.
Hi, Ian.
He's there. Oh, she can't hear you because.
Oh yeah.
All right. Okay. Est-ce qu'on met déjà le PC de Gaël? Okay. So we are going to do some tests. You're going to see us running around. What would be really nice is if you can already, just for, but not now, but in a few minutes, share your presentation in presenter view so that we can see what it gives on our side.
Didn't we say that I don't need the presentation?
You will need the presentation.
Okay, ladies and gentlemen, I hear that still some people are joining us. So maybe I give a small introduction here. So today we are going to shed some light on lupus. It's maybe a wrong term because light and lupus, they're friends, but we are trying to make them friends, okay? So I really have the pleasure to introduce you Professor Günther. She is an expert on lupus, and she has published many articles on the pathogenesis of the disease. She's participating in a lot of clinical trials. So she is really the lady that we are very happy to have here tonight to give us, to shed us some light on lupus. But maybe first of all, I want to thank all the audience, the people that are joining us tonight. And I would also like to thank our sponsors that are giving us the opportunity to make this webinar for you. So maybe I just cite them: Johnson & Johnson, Lilly, UCB, and then we have Kenfield and Leo. So thank you again, guys, for supporting us tonight to give us this opportunity. Maybe a little introduction for Claudia. Claudia, so Professor Günther, our audience is in the majority private practitioners, and we are really very eager to hear from you what is new in the therapeutic guideline. As we, as dermatologists, are really poor in therapeutic possibilities, but the rheumatologist can help us out in some difficult situations. But maybe you can give us some words on the clinical aspects and the impact of the quality of life on cutaneous lupus. Okay, can you share maybe your presentation, Claudia?
Yeah, good evening all. And thank you, Ian, for your nice introduction. I'm going to share you some screen slides, then you can see a little bit. And yeah, I hope you can see my screen now.
Everything is great, Claudia. Thank you.
Okay, so then I brought you some of the pictures of cutaneous lupus because the most interesting part in this disease is that we really have a wide spectrum of clinical phenotypes that most of you that are dermatologists will know. So we have the acute lupus with this typical butterfly rash, but can be very different presentations as well. And this sparing of the nasolabial folds, that is quite typical, not always specific, but quite typical for the acute rash. We have the subacute cutaneous rash, mostly in sun-exposed areas. We have then the different form of chronic cutaneous lupus with this discoid lesions, with this erythematous elevated infiltrates, with scaling that can be painful and often results in scarring. We have tumidus lesions. It's kind of an intermittent type of lupus that come and go, and it's also in sun-exposed areas. We have lupus profundus. It can cause tremendous scarring, and we have chilblain lesions that are caused not by sunlight, but rather than cold exposure. So cutaneous lupus is kind of a rare disease. It's below 1 in 2,000 inhabitants that are affected, but the distribution of male and female is rather about 3 to female to 1 in male. So it's more male compared to SLE, where we have rather a ratio of 9 to 1. So SLE we barely see in male, but cutaneous lupus that often starts in the middle of the middle age in about 30 to 50, then can also occur in men. And what is important about all these subtypes of lupus is that all can occur together with systemic lupus. So the most typical form of systemic presentations is of course acute cutaneous lupus, but we also can have subacute cutaneous, discoid, or the other forms of chronic cutaneous lupus in coincidence with systemic lupus erythematosus. And sometimes we might also have 2 or 3 different types of cutaneous lupus in one patient sharing with SLE or not. So this is kind of important. What is a problem in lupus disease is that when it goes on, it can cause tremendous complications like alopecia that you can see here, this scarring alopecia in this lady. You can have mutilations if you can't stop disease, and this severe scarring in profound lupus that I already showed. So this is causing pain, scars, and discomfort in the patients. Therefore, we do have an impact on quality of life in patients with cutaneous lupus. So we have a lower quality of life, we have a high rate of anxiety and depression. We have a significant rate of fatigue. Pain is causing pain, pruritus, and of course this photosensitivity. This is impairing the quality of life because you cannot participate in all the activities that are important in daily life. And especially fatigue, there's also a presentation or an analysis of the group of Victoria Wurst in the USA. They demonstrated that patients with cutaneous lupus also have a significant proportion of fatigue. What is important is sometimes only thought that it is occurring in SLE, but no, also patients also only with cutaneous lupus have this impairment of quality of life. And there was a new publication also by Joseph Merola this year in 2025, where he showed the percentage impacted by quality of life in patients with CLE. That is here the violet form compared to CLE is about the same. So with inability to work, disability, for instance, mental problems, and inability to participate in social activities. So this is similar in patients with CLE and SLE. So it's really important to have CLE. This is a disease that's really impacting the quality of life.
Thank you, Claudia. That was a nice overview, and you're really stressing out the importance of lupus on the quality of life. It's really impairing your quality of life. Can I maybe ask you, Claudia, to give us a small word on the pathogenesis of lupus? It is correct that cutaneous lupus is a type 1 interferon-driven disease?
Yes. Type 1 interferon is central in the pathogenesis, and only in the only in the last years, we going to understand that also keratinocytes are a main part of inducing this type of interferon. This can be triggered by external exposures like cold or UV light that cause damage in keratinocytes and then introduce a damage response that can directly induce type 1 interferon. Mainly, this is mediated by sensing of intracellular DNA by the sensor CGAS. This, in addition to these external exposures, can also be triggered by internal discomfort or inadequate accumulation of DNA that is not really restricted, and this can be caused by genetic modifications in different enzymes that have been described as risk factors in cutaneous and systemic lupus. Other factors that can contribute to type 1 interferon in production in lupus are the plasmacytoid dendritic cells. They might be quite frequent in various forms of lupus and are also one criteria for the diagnosis. So when you can detect them in cutaneous lesion in histology, these cells are the cells that can produce really high amounts of type 1 interferon per cell. They can be activated via their FC and toll-like receptors when they take up material from apoptotic cells or DNA that was released by neutrophils, for instance, during them producing nets. And then you have antibody complexes, and these can be taken up by these plasmacytoid dendritic cells that then produce high amount of type 1 interferon. This type 1 interferon then can kind of break the immunological tolerance. It's activating the immune system. It's inducing a chronic activation state in monocytes, myeloid dendritic cells, and also T and B cells that are then subsequently recruited to these lesions, destroy this dermal epidermal junction, and lead to the typical histological phenotype that we see in lupus. It's different in a different form. So we have more interface pathogenesis in subacute cutaneous, but more deep in the discoid forms where we also see the scarring. Why this is in these different forms is not clearly resolved, but we do see these types, and these are corresponding to the histology then.
Thank you, Claudia. It was really a nice reminder of what is going on in the pathogenesis of cutaneous lupus. Could you give us a small overview concerning therapeutics, what is currently done? I read in the ACR guidelines that thalidomide is not anymore taken up in that guideline. Is this agent out of date, or are new therapeutics as efficacious and a lot less noxious? Can you give us a comment on this?
Yes, I have prepared there a short overview of the actual guidelines, that we have in Europe for the therapy of cutaneous lupus. So what is the most important thing is that all these drugs that are recommended are clearly, at least in Europe, are not really licensed for cutaneous lupus. And this is really important because actually we as dermatologists do not have any licensed drug beside kind of topical steroids or calcineurin inhibitor, but it's strictly also not licensed, at least not in Germany, and I don't think not anywhere else in Europe. So we have, we try to differentiate between localized disease and widespread manifestations. In all patients, you should avoid first risk factors like sun exposure, smoking, or cold exposure. That is clear. If you have localized disease with only one lesion, you can use topical steroids and then de-escalate to calcineurin inhibitors. If this is not leading to remission or you have widespread manifestation, you should add short-term of systemic steroids if necessary and put the patients fast on hydroxychloroquine. There we have data that this early and fast treatment with hydroxychloroquine can prevent the progression to systemic lupus. And if this doesn't lead to remission or is not tolerated by the patient, then we advise to give methotrexate. Or, and this is also in the ACR criteria, you add quinacrine. The problem is that with quinacrine, it's not easy to get. At least for us, it's hard to get kind of permission from the assurance that they are covering this. And we also have to order this for international pharmacy. So this is not that it's so easily available for us compared to USA. So in the USA, it's easy, they use it, and it's really giving them benefit in the patients. So for us, it's more difficult. So we do have their, then I can also try to show this with the pointer. We do recommend then the methotrexate in the first part after hydroxychloroquine. So if your patient is still not responding to this, and this might occur in about half or 1/3 of the patients, then if you can find the diagnosis or can make the diagnosis of systemic lupus, then you have the possibilities to add belimumab or anifrolumab, so two biologic that have been licensed in the last years for SLE. If you don't have these possibilities, then you can add other drugs like stapzone for bullous lupus, retinoids for this hypertrophic LE, mycophenolate mofetil, IVIG, subcutaneous immunoglobulins, and also thalidomide. I mean, this is still in the list, and there are also other drugs like lenalidomide that have been discussed. It's not our first choice because of the side effects, but it's not completely outdated, but we rarely use it because of these side effects.
Thank you, Claudia, for your answer, clarifying the position of each drug and the drug escalation that we have to use in case of non-responding patients. Now, fortunately, there are a lot of new drugs on the market and under development, either monoclonal antibodies or JAK inhibitors, TLR, so the toll-like receptor blockers, Bruton kinase inhibitors, or even CAR T-cell therapies. And we are really very curious, Claudia, to hear from you. What is your experience with these new agents? And can you give us an overview of what is currently under development and drugs that we can see in the near future available for us dermatologists or rheumatologists?
Yes, Arjen, this is really the interesting phenomenon or an interesting topic in this, because we do have a lot of drugs in pipeline. So when we go back to our slide or on our picture on pathogenesis, what we do have is anifrolumab and belimumab. So they are directed against anifrolumab against the type 1 interferon receptor, and the belimumab against BLyS and BAFF that's activating B cells. And both drugs are in clinical trials for cutaneous lupus. So we are expecting soon the results on really responsiveness in cutaneous lupus. So this is really attractive to us in dermatology. In addition, we do have antibodies acting against plasmacytoid dendritic cells as a target. We have drugs targeting T cells and B cells to a certain extent. And this is a new development, that we also have drugs new designed for targeting this DNA sensor inside the cells, so targeting CGAS. And these are really completely new drugs now in phase 1 or 2 clinical trials. And we can go a little bit deeper in this topic. So what do we know about belimumab in CLE? We know belimumab quite well from the SLE trials, but all these trials were done without specifically looking to the cutaneous phenotype. So CLASI score was not included in the initial trials. Therefore, we have to rely on these registries that we have, and there is a publication from 2023 where we do see data on an Italian registry. What you can see here is a retrospective analysis of the CLASI response in real-world belimumab applications, and I do think it's quite forward. I mean, you have, after 6 months of treatment with belimumab, you have in 36% of patients a CLASI 100 response. That means complete clearance of skin lesions. And CLASI 20, so kind of improvement in 72% of the patients. I mean, this response is after 36 months, almost at 36% of the patients having a complete response. That is quite high. I mean, we don't know about the starting population, what was the CLASI and so on, but I do think it's very good data. So we have to see what our prospective trials will show. We do expect them. There was at least a study performed in Germany, a prospective one. So we do expect the data early next year. So this will be interesting. And then we hope that this drug can also be licensed in addition just for cutaneous lupus. What do we know about anifrolumab? So here we have the situation that in the initial trials, that was performed in SLE, but the CLASI was there as well analyzed, and this is important. And this is the part of patients with an at least 50% improvement in CLASI A score. And when you look to this in week 12, then you see that with placebo, this is the gray line, you have about 20%, and you have a way more, about 40%, that have 50% reduction in CLASI, so a significant improvement when they take anifrolumab. And this was also confirmed in a second phase 3 trial with this drug. But these were always prospective in patients with SLE that also in addition had an cutaneous involvement. What is the experience that we have with these drugs, or we and others have? So these are examples. So there are numerous publications about response to anifrolumab on cutaneous lupus, and only in the left side you see this publication by Carter et al., who showed a way of different types of cutaneous lupus, so chilblain, discoid lesions, here also scarring lesions, that then, if you have the before and after pictures, all responded. And it is really interesting that they wait only 1 month. So it's really fast that you see this response after giving this drug, after treating the patients with anifrolumab. And these are our own patients. You see here 4 different patients with different lesions, or either discoid lesions or acute cutaneous lupus, and also SLE-like lesions. And we did see after 3 months, it's always after 3 months, that we have really a complete response. That's the experience that we also have from other publications, and it's quite interesting. And really, it was really astonishing that we have this good response. We did analyze this in our patients as well, and we did test the CLASI activity, and you see this in the gray bar. So that's starting, and this is starting from a mean of 20, and we go down nearly 0 after the time of 3 months. In parallel goes the interferon score. So this drug is directed against type 1 interferon, and we measure type 1 interferon in blood levels. What you see is the type 1 interferon score goes down in parallel. That's what we expect, but it's not going down to the level of healthy controls. So the values are a little bit above, and that's kind of a good result, I think, because you do keep this low levels of interferon, so you keep kind of a protection against viral infection, and that is important. It's better than you would see that it's going below healthy controls. Okay, what do we know about the comparison of these drugs? Not really much, because we don't have head-to-head trials. There was one study comparing belimumab versus anifrolumab. This was an indirect comparison, but this was only done in SLE, and there, with regards to SLE, so with regards to the systemic lupus erythematosus responder index, belimumab had a little bit higher probability of being more effective. What we will see from the skin, my feeling is that this anifrolumab is faster and a little bit more effective, but we do not have this prospective trial. So this is just my personal experience. What else do we have? We have other BAF receptor monoclonal antibodies directed against the BAF receptor. This is this ianalumab. We have here the patients with the blue line, and this is proportion of patients that responded, and this is only this SRI-4 responder index. This is the systemic lupus responder index. So patients really responding to this drug, and this is higher in the patients treated compared to the others, so to the placebo control, and we do not have here the CLASI again, so it was not included in the trials. In similar type, we do have drugs that are constituted as a recombinant TATC immunoglobulin fusion, also again blocking BAF and APRIL, these soluble agents that activate B cells. So these are all drugs blocking B cell activation. And also here you see with the orange line above the placebo that there's a significant difference in the SRI-4 response rate in patients with SLE compared to placebo. Again, in these trials, we do not have any data on cutaneous phenotypes. What we do have in the CLASI is deucravacitinib. This is a TYK2 inhibitor. It's now licensed for psoriasis. It's inhibiting the IFNA, IL-12, and IL-23 with this TYK component. What we do have here is that we have about 50 to 60% of patients responding with an at least 50% improvement in CLASI. So this is nice. And we do have here some pictures also illustrating this finding. So this is patients before treatment, and you see after, and you do see a response. There's still a limited disease activity, but this is effective. And this, in comparison to the other drugs, is an oral application form that is also interesting for patients who do not want or do not like injections. Okay, this drug is currently in phase 3 clinical trial, and we're also expecting the data hopefully soon. There are also reports about other JAK inhibitors. So this is, for instance, a recent report on tofacitinib. It's only in 11 patients with SLE and CLE, but you have here in week 8 about 70% of patients with a CLASI response. I mean, this was very low because you only have a CLASI 20 here, so this is not so much, but the thing that was also important here, that they also measured the effect of the drug on the emotional distress. So we do see also here an effect on quality of life. And this is also important for the patients, of course, not only like skin symptoms, but this goes in parallel then. And I think this is also an important finding and relevant to the patients. So I did tell you about the Seeger's inhibitors in the beginning, and I'm kind of fascinated by this and happy that this comes to the clinic now. So we have the fact that when DNA is not really restricted inside the cell and kept inside the nucleus, but it's rather in the cytoplasm, and there it's probably not in vesicles or endosomes, but it's just in cytoplasm, cannot be cleaved there, then it's really a danger signal, and there it can be recognized by the Seeger's sting pathway leading to type interferon. So usually normally this pathway is developed for antiviral defense, because when you have, for instance, herpes virus DNA coming into the cell, then you activate your immune system by this pathway. But if it's your own DNA, it can also be recognized, and this is then dangerous, and you develop this type 1 interferon. And we have shown that monogenic forms of lupus are caused by defects in TREX1. It's a DNA that's usually responsible for cleaving this DNA and eliminating it from the cell cytoplasm. These patients develop very early in childhood. These chilblain-like lesions can also cause mutilations and might also develop systemic involvement like rhinos, arthritis, cytopenias, and antinuclear antibodies. And we have now 2 companies starting with phase 1 clinical trials with the Seeger's inhibitors. These are all small compounds with an oral application mode that are now starting to run. And we are curious to see how this goes in clinical practice. You mentioned as well the TLR7/8 inhibition. So there are also 2 drugs in development. One here, small compound that shows preclinical effectivity, is not yet in clinical trial. This is MH317. It's showing ISG reduction in preclinical model. And we have the one in phase 2. This is enpatoran. This has been tested in clinical trials, and we also have the results there on CLASI response. And this is here given in % change from baseline in CLASI total score. That's very interesting to us. We have the placebo line that always shows about 40% decrease, and we have the patients treated with enpatoran. That's a TLR8 inhibition and 7/8 inhibition, and we do see that here is a significant difference, and we have about 60 to 70% of initial CLASI response reduction from baseline. That's quite nice, and we already have this in week 16. So this is also promising for us that we do see this. And the interferon score that I have introduced to you earlier was also measured in this clinical trial, and we do see that it's going down almost already in week 2 to 4. And it's really a measure of response here as well. There are other drugs blocking IRAK4. So IRAK4 is after MyD88. This is in the signaling cascade of most of the TLRs, except TLR3. So the one that we showed before, TLR7/8, are also relying on IRAK4 sensing. And this is in phase 1 clinical trials. I do not have any data except this study in mice that we know, and there it has preclinical effectivity, reducing kidney histology or reducing proteinuria in the mouse model. And there you see then after treatment here, it's below than compared before. So it's effective in mouse model, and we will see what is the result of clinical trials. I did tell you that PDCs are important. You do see them in cutaneous lupus lesions, like here, we stained them here in the red color with BDCA2. And this is also the antigen. This is targeted by the drug litifilimab, and is kind of inhibiting the Fc receptor mediated uptake of antibody complexes into these plasmacytoid dendritic cells. And when you do this, you get a reduction in CLASI scores up to 50%, almost at week 16, and you see that it is true for different concentrations of litifilimab. These drugs are in clinical trials, and I think they are nearly completed now, and we will see how fast this can go then to the clinic. You also mentioned CAR T cells. These are interesting drugs that have been, or techniques that have been developed or used for SLE. So their development goes back 20 years or more, and was invented for cancer, for tumors in children, and so on. So basically, in autoimmune disease, these CAR T cells are designed against the CD19 receptor on B cells. So this is a genetically modified T cell receptor. This is cloned into the T cell. Then your own T cell is given back to the patients, can recognize these CD19 on B cells, and is destroying these B cells then because it's a killer cell, and then also eliminating, of course, the autoantibody response. And when this is given to the patients, and this is from the first publication from the group of Georg Schett in Erlangen, then you see that here after treatment, you do see an improvement of all these symptoms that are indicated here by these colored boxes, and also the cutaneous findings that you have here as new rash, and for instance here in this is then improved by this treatment. It has also and you also reached long-term remission, at least in single patients. As this is associated with the necessity to give kind of a pre-chemotherapy before this CAR T cell infusion, this is not for every patient, so this is really for severe patients, and we will see whether we will use this in patients with CLE at all. Mainly it might be used then in patients with severe profound lupus. This can be, but we will see how this development goes on. It's very interesting and might be one possibility to really cure the disease. There are other attempts to target these B cells as well, and not to use this cloning. It has to be in one more specific for the patients. So there is, for instance, this B-specific antibody teclistamab. It's also coming from oncology to the clinic here in autoimmune disease. It's combining plasma cells and T cells to bring them in close connection. It's targeting the BCMA receptor on plasma cells and CD3 on T cells, and then fostering this attack of T cells to plasma cells. And also from the same group then in Erlangen was this publication. So this is showing one patient that had been heavily treated before, and after infusing teclistamab, the kidney function rates, or protein to creatine ratio, went down. So improvement in kidney function, also the anemia here shown, hemoglobin did increase. So this was also better. And we are looking now as dermatologists, so the rash, this is here active and is reduced to zero, like the other symptoms after the infusion of the drug. So it's also promising, and it's might be even more attractive because you do not need to generate this genetically modified pharmaceutical product, because this is also available. So we will see how this goes as well. Other efforts try to inhibit this Butyl tyrosine kinase, or BTK, in systemic lupus. BTK is important, and it's an enzyme in B cells, important for activation and survival of the cells. Again, here in clinical trials, we have the systemic lupus responder index, and we do see that this is reached after infusion about in 50 to 60% of the patients, that there's some response. We don't have any data on cutaneous symptoms here specifically analyzed. So CLASI was not in this clinical trial again, so we can't say. But we do have other studies investigating BTK inhibitors and JAK inhibitors in systemic lupus. And what was interesting here, there is an indication on CLASI response, but we do see a response rate of CLASI 50, so half improvement, half reduction of the CLASI score in about 50% of patients who got or that got both the BTK inhibitor and the JAK inhibitor, but we do see 60% of patients reacting with a reduction when they get only upadacitinib. And this is interesting. So this means that JAK inhibitor alone will probably do the same job. I mean, there's no direct comparison here, but we do see that there is a significant difference to placebo. And this is interesting for us because we do have experience in JAK inhibitors. We already did see the data on the deucravacitinib, and we do think that there might be a benefit for other JAK inhibitors as well. Okay, what else do we have? We have CD40 ligand-directed antibodies in patients with SLE that are investigated. There's again the SRI4 responder index that's interesting in clinical trials. We don't have any clear response rate in CLASI, so there was no change in CLASI response. So this will be probably not so interesting for us. And it's only the BCLA response and SRI4 that are interesting for patients with SLE. Probably this ligand that is blocking the interaction between B cells and T cells is not that interesting for us in cutaneous lupus. And there have been reports at the last EADV meeting where colleagues showed that when they act the metabolites, this gluconolactone, that's kind of shifting the T cell response from Th7 rather to T regulatory cells, that in a small example of 3 patients, they could also see that there's an improvement in the active redness in CLASI score. So to see that it's less red after this week 2. So there might also be a possibility with this gluconolactone, so metabolic drugs that influence the metabolics of T cells as a topical application to improve, at least to a certain extent, these cutaneous lesions. This means we have currently only limited possibilities to treat cutaneous lupus. We still do not have any licensed drug for cutaneous lupus, but you could see that there are a lot of clinical trials are going on, and we do expect many possibilities. We have a lot of targets that are identified, and it's a very fascinating time and very interesting to look into future. The main cellular targets in cutaneous lupus are PDCs targeted by litifilimab. We have B cells. We do see belimumab. We have the CD19 CARs. We have teclistamab, and we have these BTK inhibitors. For these T cells, we have this CD40 ligands, and we have this modification of metabolic agents, this gluconolactone, all not so effective as far as we see. The most effective that we see is anifrolumab for CLE. We have it in clinical trials, and we do hope that's coming to clinic as well for cutaneous lupus. And we have inhibitors of sensing of innate signals for DNA and RNA. And we have the enpatoran as a TLR inhibitor. We have the IRAK4 here and the other TLR inhibitors. And we have the JAK-TYK inhibitors with deucravacitinib and also upadacitinib and tofacitinib in these reports. And we have a new class of drugs targeting this intracellular DNA sensor, the CGAS inhibitors that we see. So I do think this is a huge amount of new targets that we do see and new drugs that are in development. And I really hope that we will get some of them into clinic to help our patients in the near future.
Thank you so much, Claudia. It is really amazing to see what is happening here in research. And also, even if there are still some large trials to do, and to see what are the side effects and the adverse events of all those agents, it's really amazing to see what we can do, and really hope that in the near future the young colleagues can treat lupus differently than we did previously. So,
Yeah, hopefully.
dear Claudia, I would like to introduce to you two of my colleagues here, a young dermatologist. So he will live lupus differently as I had, and we also have a chance to have Dr. Malaise. He's a rheumatologist, and they would like to share with you, Claudia, a difficult case of lupus. And maybe Thibaut, you can start with explaining, because you started to see the patient 2 or 3 years ago. So maybe you can give us a little introduction on what did you see and what did you do with this patient?
Yeah, so the patients first arrive in dermatology consultation with these facial hematous rashes, and she also had this scaly hematoses lesion on the upper chest.
It was everything, or did she have other skin signs?
She also had a lesion here on the upper back, and she explained that she has been told she had allergic dermatitis, but it wasn't going very well, so that's why she came to see a dermatologist. And obviously, it wasn't some allergic dermatitis. This lesion with a young woman on the facial area, and she also said that she had photosensitive reaction, so it was quite obvious for us lupus. So
okay, so clinically suspect of lupus. The history is like lupus. So did you do any complementary examination?
So as a good dermatologist, first a skin biopsy, and we had histological confirmation for a subacute and DCAPSULE lupus. So then we start to follow her in our dermatology department.
Okay, you see, as a good dermatologist, but you did some blood tests.
Yeah.
Is that right?
We also have the blood test, so we saw that she already had systemic involvements. Especially she had dsDNA positive and anti-SSA, hypocomplementemia, antiphospholipid antibodies were positive. Although she didn't have experienced thrombotic events. She complained of inflammatory arthralgia, but had no renal, neurologic, or visceral involvement.
So now we are clear dealing with a young patient with a severe impact on her quality of life, with signs of cutaneous lupus and systemic lupus.
Yeah.
So what was your treatment approach in this patient?
As we saw earlier, we start with the basics. So we told her to stop protect with the sun, to stop smoking, and we start hydroxychloroquine. It was ineffective as monotherapy. So we move on to methotrexate and start at 15 milligrams per week and move on to 20. But the patient experienced poor tolerance. She had asthenia and GI tract disabilities, and on the skin, it was limited skin. In March 2023, we had to stop the methotrexate because the patient had a pregnancy in wish. So we stopped the methotrexate, and a few months after, she unfortunately had a really bad alopecia flare. So we need to hospitalize her and to start high dosage or IV methylprednisolone.
Okay, so but we were relatively limited in this patient.
No more therapy or backpack.
So we asked help of our rheumatologist.
Yeah.
And maybe Olivier, you can comment on what did you do afterwards, because we were running out of therapeutic possibilities.
Yes, so as you explained, it's not probably just a cutaneous lupus, because we have many biological signs of activity. We have low complementemia, we have double-strand DNA, so we have really a strong cytokinic RH. It's also more than skin lupus because we have arthralgia. It was really inflammatory arthralgia, so there is probably needs for more systemic treatments. And at this time, according to the reimbursement condition that we get, we decided to give anifrolumab to the patients. So antibody against interferon receptor, and it was really very effective with a very quick cutaneous improvement, but also a very quick reduction of the inflammatory signs in the biology and in the inflammatory arthritis that the patient gave. Unfortunately,
you experienced some side effects, some adverse effects with this treatment?
Yeah, we get some side effects, not immediately, but she had recurrent infections. And so we decided to stop the drugs because we were in remission in the skin. We tapered the glucocorticoids, and after there were still some skin relapse. So we decided this time to try belimumab, which also have the advantage after the intravenous injection that can be given by subcutaneous injection. And the patient plans to live outside Belgium, so it probably will be easier. And we have also a very good clinical response on the skin, even if this was more slow than with the first drugs.
Okay, thank you very much. So until now, what do you think of this case? Do you have any specific recommendations, Claudia, or do you think this is a good situation? I think, yes, do you have another comment on the...
Yes, I think it's important to make the confrontation between your guidelines and our guidelines. So I also decided to show you some guidelines. There's the very recent guidelines from the American College of Rheumatology. It's not for cutaneous lupus, but it's for systemic lupus with cutaneous involvement. As you can see, it's at the beginning the same, hydroxychloroquine for everyone, pulse of glucocorticoids if there are some risk for an organ, and here the hair is considered to be an organ. But in the mucocutaneous side, when we have a moderate to severe involvement, or the fourth choices that we have is methotrexate, but our patients already have methotrexate, is mycophenolate, but there are high rate of adverse events, also some infection. And I mean, the second lines after hydroxychloroquine is also, as you propose, anifrolumab and belimumab. But I just have a comment to do with this. We are in Belgium, so of course it's difficult to give and to get the drugs. And there are some quite strict reimbursement conditions for these two drugs. I just would like to show you which are these conditions. First, I will go to the third one. You need to have immunological and hematological signs of lupus. Not so difficult to get. You just have to need the presence of antinuclear antibodies higher than the usual titer, or you can get double-strand DNA, or you can get defect of the complement factors. It's quite easy to get, because if you have a systemic lupus, you need to have the presence of antinuclear antibodies, so it's quite easy. Then I would like to come to the first point. It's, I mean, in Belgium, only able to use on the fourth place as a drugs. It means that you have before to give antimalaric drugs, so hydroxychloroquines, to your patients. Your patients should have received 3 months of low to moderate dose of glucocorticoids, and your patients should also have received another immunosuppressive agents, like in your patients, levetiracetate. Of course, if you have contraindication or if you have intolerance, you can skip 1 or 2 of them. And lastly, and it's probably the most difficult, you have to need a high systemic disease activity with a Selena-SLEDAI higher than 10, or just at 10 or higher than 10, which is quite difficult to have. Selena-SLEDAI is quite a scale where you make a score for each organ which is involved. For example, if you have involvement of the brain or the central nervous system, you have 8. If you have an involvement in the joint, you have 4. But if you have a rash or if you have a skin involvement, it's only 2 as a point, or you can have only 8, but you have signs of severe activity or 2 moderate activity in 2 organs. So it's not easy to get this, but that I think the importance to make a collaboration between the rheumatologist or the immunologist and the dermatologist, because most of these signs to get the reimbursement for these 2 drugs come from other organs or come from the immunological data from the patients.
Okay, so currently the patient is treatment like is shown here on the slide with belimumab and hydroxychloroquine and the topical tacrolimus, so the calcineurin inhibitors. There is marked continuous improvement. There is stable serological profile, and there are no systemic symptoms. So do you have any comment? Would you do something else, Claudia, or would you suggest to maintain this option? What is your vision on this?
Mm-hmm. I think it's a very interesting case because it's summarizing or comprising all the symptoms that you can have, and it may complicate the case. So you have cutaneous involvement and severe systemic involvement. I do think the most important is a good interaction and interdisciplinary care between dermatologists and rheumatologists. In this case, that was also done in your case, so that's really nice. And we also already try to have this and to have this interaction, because then we can only learn, and it's for the best of the patients. I mean, when you added the hydroxychloroquine in the beginning, how long did you wait for the decision it's not enough? When from your presentations, what is half a year, 6 months, or only 3 months?
That was at least half a year, Claudia. So
Half
it
a
was
year.
long
I mean,
enough. Yeah.
So
because
this
you have
is
slow
long
responders.
enough. So this was
Yeah.
even long enough if this is patient. So then, I mean, if the patient really has severe involvement, we would kind of nowadays use anifrolumab then in the first place directly after hydroxychloroquine. I just hear that this might be difficult in your country, so it's hard. But I think also from the discussions with the colleagues in the United States, I mean, they also recommend that you use this quite early, even I think if this is a severe cutaneous involvement before methotrexate, because with methotrexate you still have to wait again for 6 months until you get a complete response in some of the patients. At least you have to wait 2 months until this is effective, and this might already be too late for some patients who develop scarring or severe ulcerations. So as you did, I think it's reasonable, but we should keep in mind that should be our aim to use this well and fast-acting drugs really early in the treatment if we have severe cutaneous involvement. And it would
So
be
you also
really,
sustain the fact that we have to hit hard and early in order to have a better disease course.
Yeah. It would be interesting to me, how did you see, I mean, you reported it also, the arthritis and systemic symptoms responded quite well also to anifrolumab. I don't know, what was your feeling on the kidney involvement? Because we had some patients where we did see that this was not as fast or well responding. I don't know, what was your impression in this patient?
Can you give a comment on the renal function in this patient? Did she respond well? Or
I mean, there are no renal involvement in this patient,
Okay.
but what we but for the joint involvement with ledatrexate, we already have quite a good response with these drugs. But when we stop it, we have, of course, also a relapse, and we have not really exactly the same response with the joint that with the skin. And also, if we look at the ACR guidelines for the treatments of arthritis, anifrolumab and belimumab is also at the top of the drugs that we could use. Even after hydroxychloroquine, if I have the choice, I would also prefer to give these drugs than giving methotrexate for my patients.
Yeah, that's correct.
Okay, Claudia, we would really like to thank you. Maybe just one little question, because we were shedding light on lupus. A lot of light-based devices like laser therapies, they are using light. So do you think these treatments are contraindicated in patients with lupus, or is just the amount of energy not enough to induce any crisis of lupus? And can those laser therapies be safely used in patients with lupus?
I mean, there are even reports on laser treatment in lupus patients. So some of them might be responding just for the cutaneous types. So it might be an indication as well on this. But you mean if you have kind of healthy skin and you do some of laser treatments in those patients? Yeah, I do think in most of them it's safe. Yeah,
it's safe to do. Okay.
I mean,
then maybe we would like to wrap up. I think it's well, first of all, I think we have to thank you for this marvelous presentation on everything that is available, everything that is in the pipeline today. Also, from our point of view as dermatologists, we are really limited in possibilities, and we are really happy that we have this collaboration with our colleagues rheumatologists. I think we should not forget, as you also told in the previous part, the psychological and cosmetic burden of the disease, particularly alopecia and photosensitivity. So the infectious issues, you do not have a lot of problems. So that's nice in terms of safety. So again, I think, and one of the challenges is in this disease, I don't know what is your opinion, but because this disease is long term, you see the patients a lot of time, you have to change a lot of therapies, and you have pregnancy issues. So it's really important to have a long-term follow-up and a good patient compliance and a very good relation between you and your patient in terms to keep her on track with a nice skin. So again, Claudia, really, I wish again to thank you so much to giving your insights. I also wish to thank our both colleagues for this challenging case that was really demonstrating the interaction between those two specialties. And again, I have to thank the sponsors for giving us the opportunity today to give this webinar. So thanks to Johnson & Johnson, Lilly, UCB, Canfield, and Leo. And some last issue, please answer the survey that you will receive to rate our webinar. And you only have to give us the good points, because we need those points and you need those points. And it was really fun for us to do this webinar. And I personally learned a lot here. And I think our colleagues also, they did. And we really appreciated, Claudia, that you give us the opportunity to interact here with you. Okay, dear colleagues, again, have a nice evening. Thank you for joining us on this webinar, and I wish you a good night. Bye-bye for everybody.
Thank you.
Bye. Thank you. It was a pleasure.